So, as Ian said, I'm an occupational therapist working in Heathvan unit, which is our unit that's in Wrexham. So we've got 72 beds. Our occupational therapy service actually covers not just the older person side, but also the adult side as well. So my time is split around all of those 72 patients. The wards that Ian's talking about in the main, that's a 14-bedded dementia ward that this data's been gathered from. In terms of my role, I've noticed that that's changed quite considerably really, that when I did my rotation about 9 years ago on that ward, most of our patients were actually returning home. So my role as an occupational therapist was, how can we get these people back home? Whereas now, as Ian alluded to really, the patients on that ward have got very severe dementia, and actually the majority of them aren't going home but are actually going into EMI nursing placements. So my role has considerably changed from what I was doing 9 years ago of facilitating how can we get these people back home. It's now what can you do with these individuals to help the team engage with them, and how can you help advise what level of placement they require, and how can we help them to have that meaningful engagement which was talked about earlier. It does feel a bit like a College of OT conference really. I was joking about that earlier. But I think that this has been a great tool for us to use. I think some of our conversations, myself and Ian was talking about how this has really been a tool as part of something wider for us really. So my role now really is trying to look at what we can do as a team to identify from someone getting up in the morning to going to bed at night, what is their needs, so that we can hand that on to wherever they're going afterwards, but also how do we help them when they're on that ward? Because as you're probably all aware, it's difficult getting these placements for people now. We've got a shortage of placements available for people with severe dementia. So actually the patients on our wards are often there for a long time, perhaps months now. So it's about how do we help them during that period to keep them well, and also to find out how to support the placements they're going into. So the DRTS has been really helpful for that, and we're also using this for the PAL as well, the pool activity level. We found that what the DRTS does is open things up for us. So I think as people have been talking about, it's those meaningful conversations that take place. You can't sit down and do an interest checklist, but what you can do is that you sit there with the DRTS and there's something that will capture people's interests. And from that, you go on into another conversation really. Some of the examples that have taken place with our patients is perhaps there was a gentleman who we had who we weren't able to get many conversations with him. It seemed that everything we were trying, nothing was coming back. There was no spark with him. I liken it to fishing really, that you're kind of throwing the line and seeing what catches with an individual, and there was just nothing. There was nothing coming back of interest from them. But we opened up the regional aspect and clicked on the pictures of his local area, and suddenly he started to talk about some walks that he'd done, and it led to this conversation about these very extensive walks that he'd spent most of his life doing. Then we could open up YouTube and go on to picking up those areas. So something which we'd had great difficulty to keep him engaged for a couple of minutes of a conversation. Now we were there for 30 minutes going through the sort of walks he'd done, and lots of old memories coming out. And I think one of the things that does was about these shared experiences that take place. Ian and I were talking about some of the similarities of things that we've done in our careers, working a lot with people with psychosis and people with dementia. And one of the things that draws those together is the fact of this altered sense of reality, and that person's reality is different to your reality. But actually what the DRTS is doing is bringing us together and giving us a shared experience. So we're both able to look at the same thing and able to talk about it together. And that's been really helpful for us. We are finding that this is incredibly helpful for being flexible for us as well. That, again, as you're alluding to, it's difficult to perhaps provide a bunch of tools on the ward. And if you do put them on the wards, then you've got to think about infection control. Whereas what we're able to do is take one item, and from there you're able to actually do a wide variety of activities with patients. The aspect of that I love as well is that there's always something that someone enjoys on there. I've never yet taken it to anyone, and they haven't been interested in anything. So we are using this quite effectively. We've got the next bit we're going to be doing is about families as well. We've got our whole ward team are using this quite regularly, but now we're going to be doing that with families as well, because I think it's difficult when families come in. Often it's, well, what do I talk about when I'm sat here with my loved one? So we're going to be training families on using this themselves, so that again they can sit there and use this with their loved one. Again, that intergenerational thing that's already been talked about, of someone in their teens or in their 20s sat there using something with their grandparents. That's what we're looking at next, really. But we are finding this has been good as part of a tool. I would say that our biggest thing is always that a tool is only as effective as the person using that. So what we've done a lot of is trying to train the team on how to use this, and what the aim of it is, that it's around meaningful engagement, it's around those meaningful conversations that have been talked about before, and it's about trying to provide something which helps you to understand who is this person who's in front of you. Never forgetting that this is a real person. It's not, as Ian talked about, it's not that this is Mr. Dementia. This is a person who is a living person, and actually we need to capture who they are. And this has really helped us to do that. And part of our transition work now is that we're able to go, well, this is this chap, and when he's moving into this placement, these are the things that you might need to consider. These are the activities he enjoys. And even if they perhaps haven't got a DRTS, it does give them an idea of the activities that they can be incorporating in that patient's day-to-day life when they move into placement. So it's part of a wider tool of things that we're using, but it's certainly been very effective for us. I would say one of the things that challenged me as an occupational therapist, I don't know if others have found that, was that I did walk onto the ward one day to see that the DRTS was in the middle of the room, and there were 6 patients who had just sat around it in a semicircle with the activities worker. Initially I thought, well, that's not what it's for. It's not just to be there to be looked at. But then I walked past and looked again, and as Ian said, we have these patients who have very severe dementia. I thought, well, actually there's 6 patients sat together watching this, and then I looked at their faces and I saw that there were smiles, I saw that people were laughing, and I looked at what it was, and it was faulty towers. And I thought, actually, well, this is something that brings people together. There's a uniting that it does. And I think that it does have a great flexibility for our service users to be working with. That's about all I've got. I don't know if there's any questions that people have got. Ian's put me in the firing line for that.
When you do life stories and families and pictures and that, what do you do with the information after that person has moved on?
That's the bit that I'm hoping to find out from some other people here. Because what we've had is that traditionally we had been writing life stories on a computer ourselves with patients and using different formats of that. What we quite liked was what's on the software to use, but we decided we'd go with what we could use straight away off the software, which was all of the reminiscence activities and so on. We use those first, and then work out how to use the life story stuff afterwards, because we've got things like information governance to think of, and the fact, so we've not yet solved that bit, but we're hoping that we can find out from the people in this room who are using that aspect how they did that with their IT departments. So perhaps it's a wider question to ask, I guess.
Hi, I'm Chris North. I'm Dementia Lead for Bradford District Care Trust. I'm intrigued really to know whether you've managed to gather any evidence of the information that you've passed on to family and carers in terms of them using it beyond the stay in unit.
At the moment we haven't, and that's the bit that we're now looking at. So we wanted to get that quantitative data. That's the bit that we've been missing. So we've got the wonderful stories of saying, this has really helped me, this has helped my family. We've got those bits, but we now want to get that quantitative, and that's what the DCM bit was, is the first bit is to see, could we get something about snapshots on the ward, and then what can we do about the effectiveness of, perhaps like our patients staying in those placements and having more fulfilled lives there than they were previously. But then how do you capture that? So that's our next quandary, really.
Thank you.
Okay.
So, a lot of my clients that, I mean, I can only speak for ones that have fed this back to me, but there's a number of things that you can do when people are discharged. Obviously, from a data perspective, you would take them off the unit, so you would delete them. Once you've deleted them, that information isn't stored anywhere, so that literally just, it disappears completely because everything's contained in each individual unit. What you can do, so for the life books and for the life collages, they can, if you're on Wi-Fi, they can easily be emailed to the families, so it's a usable document for them in any other environment, which is one of the easiest ways to do it. It just goes through to them as a PDF. Alternatively, you can obviously print it off, so there are some copies. I think everybody's got a copy of the collage that can be printed off on any printer. You can print life books on normal A4 paper, or you can have them printed from any high street printers for about £25–28, which are lovely legacies for the family and very supportive as well in any environment that the patients may go to. But it's very, very easy to save the information and to store it. The patients' families as well, and I do say this because I know every single person in this room will have had a directive from your trust that you're not allowed to use external memory sticks in any of your devices. Everybody nods, no, you're not allowed external memory sticks. These devices are different, so they don't connect to your networks, they don't have any security implications for you. So the family members can bring memory sticks in and actually save the information to a memory stick as well, and then they can use it on any of their devices. So the point is to try and make it as transferable as possible, so that any of the work that you've captured as caregivers in terms of life books that maybe you've worked with that patient on for a while, and the collages can then be transferred to the families to use in every other environment that they may go to.